Time. We'll get started to let some others trickle in on their way. So good morning and welcome to the Institute for Pandemics Research Rounds for Graduate Students. I'm Ted Konya, the Associate Director of the Institute. Before we begin, I just want to acknowledge the land that the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land. A few housekeeping items also before I begin. This is the first time I'm using Teams webinar, so we'll see how it goes. If there's any issues, just reach out to me in the chat. But attendees are all automatically muted, so when there are questions, you can use the raise your hand feature, and then I can unmute you, or you're welcome to ask any questions in the chat. And the webinar is being recorded, so we'll make it available on the IFP website at a later date. And now I'd like to introduce our moderator for today, Dr. Renzo Calderon. Renzo is a postdoctoral fellow at the Institute for Pandemics under the co-supervision of Drs. Jeff Anderson at the Institute of Health Policy Management and Evaluation, Shauna Burrell at the University of Toronto, Mississauga, and Simone Bagat at the Temerity Faculty of Medicine. Renzo completed his PhD in epidemiology at McGill University and achieved an MD and an MSc in biomedical informatics in global health from Cayetano Heredia University in Lima, Peru. So Renzo, I will let you take it away now.
Thank you, Ted, and hi everyone. Thank you very much for coming to our webinar. This is the first of a series of different sessions that we have from the Institute for Pandemics, and we're really pleased to have our speakers today. The idea is to showcase the different areas of research, especially research that involves different fields, and how research during COVID or COVID research could be enhanced with these multidisciplinary activities. So our first speaker will be Professor Andras Tilcsik. Professor Tilcsik holds the Canada Research Chair in Strategy, Organization and Society at the Roman School of Management. His research focuses on organizations, occupations, and work, and he is particularly interested in the causes and consequences of inequality in labor markets and the workplace. Dr. Tilcsik.
Hi, everyone, and good morning. I'm also not a frequent Teams user, so let me know if anything is not working. So let me try to share a few slides and then see if we can get that to work. Can you see my slides?
Yes.
Awesome. All right, great. So the research I want to talk about, so this is part of a bigger project with several co-authors, and I just want to focus on one little aspect of it that is maybe the farthest along. And again, thank you for the Institute for hosting this and for supporting this work. This study is about COVID impact statements, which are fairly popular intended intervention to reduce pandemic-related inequality in academic science. Really the motivation for this work is that we know from a lot of prior work that COVID-19 has disproportionately affected female faculty in a lot of academic institutions. We now have quite a bit of research showing that during the pandemic, women took on more caregiving than men, both in academia and in many other fields. We know specifically in academic science that publication progress, especially for women, especially for those with children, young children under the age of 6, has considerably slowed over time. And at the same time, we also see some evidence of increased service and kind of teaching demands for female faculty, often being involved in having to provide emotional support for students and sort of taking on all these other roles while at the same time dealing with all these caregiving responsibilities at home. We know that this might be especially consequential for women who are pre-tenure, and as a result, this kind of big disruption may have long-term effects on the gender composition of the professorial ranks. And there's been a lot of conversation around this in higher education, and a lot of concern about how most appropriately to address and kind of take into account the disruption. So people have proposed all kinds of ways of dealing with this. One is the focus of this work is this COVID-19 impact statements, which go by different names, but it's essentially at different institutions. But essentially, these are statements that people, when they are going up for tenure or some other kind of promotion, they can use these statements to document disruptions to their careers, to their research, explain the nature and the significance of the disruption to their work, and excuse me. And some people have really seen this as a kind of a powerful way of contextualizing people's performance, and as a result, helping to address the disruption due to the pandemic. But at the same time, others have raised all kinds of concerns about the possibility that these statements might actually do more harm than good, that they might in fact backfire. So the first position is this notion that COVID impact statements, essentially what they can do is that they contextualize merit. I can put my performance into context. I can explain these sort of structural constraints, my caregiving responsibilities, the shutdown of my lab, whatever it might be. And as a result, evaluators can make more appropriate judgments of my record. And as a result of kind of being aware of my situation, they may be more likely to attribute deviations from expected productivity to external factors that are beyond my control, rather than internal factors that reflect upon my productivity as a kind of underlying productivity or underlying qualities as a researcher. So this is usually the argument people make for using these kinds of statements. On the other hand, again, there's lots of voices that question this approach and have raised a number of concerns about the possibility that COVID impact statements might in fact backfire or might not really help move the needle in the direction we would like them to. One key concern in this area is that there's a risk that these statements may make salient to the evaluators certain identities or responsibilities that are stigmatized and are sort of conflict with kind of ideal worker norms of total work devotion that we often see in academic science. We know that motherhood is in certain ways can be especially a sort of stigmatizing identity in professional workplaces, including academic science. We know that both in science and in many other fields, employers often view caregivers, both men, women, and of other genders, as less competent employees, as less committed employees. And so there's a risk that if I document disruptions, especially disruptions due to caregiving responsibilities during the pandemic, I make that identity more salient, and that may result in more negative evaluations of my record, because I draw attention to these identities and responsibilities that are typically perceived negatively, or in quite a bit of research so far. So the jury is out there on sort of whether these things help or hurt, and that's really kind of where we come in. And we were particularly interested in these three sets of questions around COVID impact statements. One is really just the main effect. So what happens if we include these statements? Does that affect, and how does that affect tenure evaluations? And we'll be focusing for this particular study on the physical and life sciences. tenure candidates in that space, and then a couple of secondary questions on sort of does it matter what's the content of the impact statement? Does it matter what the nature of the disruption is? Does it matter if I had to if I experienced a slowdown in my productivity because my childcare center was closed for 6 months or a year, versus if my lab was closed for 6 months for a year. So for that, we are sort of trying to hold the amount of disruption, the degree of disruption constant, but vary the source, because with the childcare one, again, these potentially stigmatizing identities are made more salient than with the lab closure, which is sort of more technical and kind of less directly reflecting on, or less directly making salient caregiving responsibilities and motherhood and things like that. And then we were also interested in whether these effects, any effects that we might see, whether they vary by the gender of the faculty member, or perhaps the characteristics of the evaluators who are reading that tenure dossier. So again, we'll be doing this in the physical and life sciences context. We know that especially in those fields, these sort of ideal worker norms are kind of highly prevalent. Sort of the ideal worker as somebody who is always there, is fully devoted to their work, somebody who has this calling for science. And we know that this sort of caregiving biases often show up quite prominently in those kinds of fields. And then we also know, of course, from a lot of other work, that gender biases are often a bit more pronounced in male-dominated or kind of male stereotyped fields. Again, in physical and life sciences, they tend to be relatively more male-dominated in sheer numbers than the humanities or parts of the social sciences, but there's a lot of variance among PLS fields as well, which is interesting and kind of allows us to also look at whether these effects vary among different physical and life sciences fields. Some that are more male-dominated and others somewhat less so. So what we did in this work was as a first step, we conducted a survey experiment with faculty members. This is this is sort of not a perfect method in many ways. We kind of lose a lot of realism of what happens in the field, but in other ways, the kind of artificiality of the method is helpful, because essentially we are able to survey a bunch of tenured full professors, the kinds of people who tend to sit on tenure committees and have lots of experience with them. We do this in physical and life sciences fields among faculty at US R1 universities, so the sort of more research-oriented universities. And we are able to give them, everybody gets a fairly realistic package of, this is what's called a summary of evaluation of tenure case from a university committee. And so they get to imagine that they are sitting on an adjudication committee for a tenure case. They get a bunch of reports about this candidate. This is a candidate in the in a lab-based life sciences field. They get a bunch of information about them. They get some letters, snippets of letters by external letter writers, some information about research, teaching, service, the usual kinds of things. And so we did a lot of work prior to running the experiment to pretest these materials. So they are quite realistic as far as possible. And so we can hold all that constant. We can hold constant the actual performance and kind of performance indicators of the person going up for tenure, and then we get to vary the things we want to vary, which in this case is the presence of a COVID impact statement, and whether that statement talks about a childcare closure or a lab closure, or in the third condition, the sort of control condition, there is no statement at all. And the childcare closure versus the lab closure setup is essentially identical in terms of the impacts that are documented. The only thing that varies is whether it's the lab that had to be shut down and that's what caused the disruption versus the childcare center. And so the first one would be expected to kind of make more salient these caregiving biases, and then we also vary the perceived gender of the candidate simply with their name. So it's either a female or a male candidate. So essentially, this is a 3x2 design, but everything else other than the statement and the candidate's name is identical. And each evaluator receives one one of these packets. We have a little over 600 full professors from these research universities who have read these materials. And then we ask them a bunch of questions, evaluation questions about the packet, including whether they would recommend promotion with tenure. We ask them some qualitative questions, and then we also ask them a bunch of questions about themselves. So we have some data on who these people are. So just a quick overview of some of the key results we are seeing so far. So this is a graph here. The dependent variable is the strength of a positive recommendation for promotion with tenure. We have a number of ways of measuring this, but they all essentially show the same pattern. People who included candidates with a lab-based impact statement or the childcare-based impact statement received significantly stronger evaluations than the candidate in the control condition. This pattern is quite similar whether the candidate was male or female. We can't really reject the null of any that kind of these patterns are the same for men and women. And so this is somewhat surprising in light of a lot of prior work in kind of more broadly and sort of professional fields, but particularly in academic science, where there is quite a bit of prior research documenting these biases around motherhood and caregiving. And so what we find is actually sort of the opposite of what we see in quite a bit of prior work. Of course, COVID is also different than I think a lot of the sort of previous situations that have been documented in prior research. And so two things that sort of stand out right away is that one is that unlike a kind of personal situation that an evaluator might judge to be or might perceive to be in part a fault or some sort of defect in the candidate's record or career or in their life, COVID is kind of more reasonably seen as this externally imposed disruption that's beyond the candidate's control. And as a result, it might not be as easily attributed to the candidate's underlying characteristics. Second, this disruption is also this sort of discrete temporary event that was in the past, or kind of a large part of it was in the past. So it might not be seen as a risk to future productivity. It might just be seen as like, hey, this happened, this was a disruption, but it didn't reveal anything kind of long-term and inherent to the candidate by itself. And when we look at people's qualitative responses on the survey, when we ask them like, okay, now explain why you would or would not recommend this person for tenure, why would you or would you not advocate on their behalf if you were on a committee? A lot of the times we do see some evidence consistent, especially with the temporality aspect of that. So often people will talk about, oh, this was this temporary negative influence, these are temporary productivity issues. And then people will also, many of these faculty members commented on the uncontrollability of the disruption. So this is something that's clearly seen as beyond the candidate's control. And as a result, once things get back to normal, they say, I'll expect their productivity will improve. And then we did a little more, we are still working through this, but did a little bit more work on analyzing these open-ended responses using LIWC, the Linguistic Inquiry Word Count, which is just really a dictionary-based way of measuring certain types of words. And we do see some evidence that when people are making these hypothetical tenure recommendations and evaluations, when they see a statement, either lab closure or childcare related COVID impact statement, they use terms that are associated with temporality, when, now, then, and terms that focus on the past, like was, did, ago, much more frequently than when they don't see, when they are not presented with a COVID impact statement. One thing, just kind of very quickly highlight this because I'm almost out of time, is that we started to dig now into the into variation by evaluator. So, for example, do female senior faculty evaluate these statements differently than male senior faculty? Do people who themselves have had caregiving responsibilities during the pandemic or have been more affected by the pandemic, do they evaluate them differently? Which is, of course, a sort of a potentially important kind of higher ed policy question for how we think about putting together committees if we are thinking about equity. So we don't actually find a lot of evidence consistent with those types of variations. What we do see is that university rankings, kind of university prestige, seems to matter in that at the kind of most elite schools, at the sort of highest prestige schools in the top 10, top 20, top 30, the effect seems to be the boost you get from including a statement seems to be much more muted. So at sort of these sort of elite, among evaluators who were included in our sample and are at the sort of most elite research universities, having the statements didn't make things worse, but they didn't seem to move the needle as much as at other good but not quite as elite research schools. So we are still trying to kind of figure out what that means and what the implications of that are. I also don't want to make too much of this particular finding because, again, it's relatively small samples, and there's, of course, self-selection from different people from different institutions self-select into taking a survey, but it's an interesting pattern, and I've been hearing from colleagues working in related areas of sort of seeing similar variations around other policies that relate to gender equity in academic science. So in a couple of things we are seeing so far, somewhat surprisingly, but it's a positive surprise, COVID impact statements, at least in this sort of fairly constrained survey experimental setting, do seem to have a positive effect on perceptions of both male and female tenure candidates. Not sure yet what the mechanism exactly is to explain why this is different from what we see in a lot of prior work that is not related to pandemics, but one hunch we have is that this is probably related to this temporarily discrete nature of the disruption. And then we are starting to explain or explore variations in treatment effects by different characteristics, and we do see some variation by university prestige. Thank you.
Thank you very much, Dr. Andras. Very interesting work. I don't know if someone from the audience has questions. Please feel free to raise your hand or unmute it. So I'm not sure if I can see or if they have put
No,
it in the
nobody,
Q&A.
nobody's raised hands. So if they do, then I will be able to unmute them.
Yeah, but I was wondering, Dr. Andras, you mentioned that the impact statements were related to disruption, right? It's either lab disruption or childcare disruption. I was wondering there is a case for impact statement that actually are like in a positive, like no disruption, but actually made you more productive. If that is something that happens or not.
Yeah, so I haven't seen, so, when we constructed the experiment and created the stimulus materials, we actually reached out to lots of people who have used these statements or were thinking about using these statements. And I mean, so we tried to make it as externally valid as possible. We actually sort of use language that is quite commonly used by people. And most of the time, the things that people document are these negative effects. But I think you raise an interesting question in that if I'm an evaluator and obviously I know that like you're coming up and you had your some of your productivity or kind of some of your record took place during the COVID years, I know that like that might have created a disruption. What's my interpretation of your record if you don't document anything, but you had an opportunity to do so? So that's maybe something that we can dig into a little more, because I think people still make all kinds of attributions about, what does it mean if you don't say anything?
Yeah. I think, yeah, thank you, Dr. Andras. I think I have a question in the chat from David. Thank you, Dr. Andras. Subjectively, do you think there might be less sympathy as time goes on? Like if recent waves are viewed as less severe?
Yeah, I mean that would be my prior as well. So that would be sort of an interesting and kind of empirically tractable thing we could look at, right? Like rerun this a year from now. I think what would be interesting to know is whether, sort of which aspect of time does this react to? Is it the, I go up, it's a long tenure clock institution. The disruption was still in 2020 or 2021, 2022. Now I go up, it's 2026. Do people forget how bad it was? Or so it's like that's one possibility, or do people still remember that? Another one is that, of course, there is, there are some people who might have lasting effects that are just happening now, and then people might be less forgiving of that as well. And I think if it's true that this has something to do with the kind of temporality of the event, I think, and that we are more forgiving because we kind of see this as like a one-time thing that was relatively short, time-bound, and that happened in the past, then we might expect that if somebody is documenting lingering effects, and as time goes on and we kind of forget how bad that event was, then maybe some of the sympathy effects will go away. It's an interesting testable question.
Any other question? Great. Thank you, Dr. Andras. But do we have time for another question?
There's time, but if there is none, then maybe we could move on to Dionne.
Yeah.
Thank you.
So Dr. Andras, thank you very much. Okay, so following up, we have Dr. Dionne Aleman, who is an associate professor in the Department of Mechanical and Industrial Engineering at the University of Toronto and holds appointments in the Institute of Health Policy Management and Evaluation and the Institute of Academics and the UHN Techna Institute. She is also a colleague for the Joint Translational Center for Digital Health, which is a collaboration between the University of Toronto and the University of Manchester. Thank you, Dr. Aleman.
All right. Thank you, Renzo. I think everybody should be able to see my screen. I hope. I've never done a webinar. Okay, so I'm going to talk about interpretable surrogate modeling for agent-based simulations to better inform COVID-19 or really any pandemic decision making. So first off, what is AI anyway? AI is the hot new thing. Everybody talks about artificial intelligence, machine learning, but AI and ML are actually two different things, and it's helpful to sort of separate out what are they. So according to IBM, artificial intelligence leverages computers and machines to mimic the problem-solving and decision-making capabilities of the human mind. In other words, using computers, mathematics to make decisions, but newsflash, we've been doing that since World War II. It's called operations research. It is a major branch of industrial engineering. So this idea of AI has been around for a very long time, but the idea of adaptive learning and prediction and whatnot is the more newer topic that everybody is really think of when they think about ML. But I'm actually going to talk more generally about AI, including some ML work that we've done around pandemics and COVID explicitly. Okay, so in my lab, the Medical Operations Research Lab, more lab, we've actually been researching pandemics, not since COVID started, but since just before H1N1, so well over 10 years now. We originally started this work looking at the Greater Toronto Area and a very large agent-based simulation, working with what was then called the Ontario Agency for Health Protection and Promotion, now more succinctly called Public Health Ontario, just to answer some basic questions about, what if we implemented a policy like this? What if we have flu clinics like that? How might that change how disease spreads? Now, in addition to that simulation, we also incorporate mathematical optimization and machine learning techniques to, again, predict pandemic disease spread under various scenarios, which do include various mitigation strategies, vaccine prioritization optimization. So, all of those phase 1, phase 2, phase 3, phase 4 of who gets vaccinated, how are those determined? And can we determine them in a really smart way to make the best use of limited vaccines, as well as looking at severity prediction. So with this work, we worked for Newfoundland and Labrador since March 2020 on their COVID analysis and policy design. So a little bit about our large-scale ABS. It's large, so we have an entity, an agent for every single person in the population. So for Newfoundland, that's 500,000 individuals. And we have all sorts of information about them, like where are they located in terms of census subdivision, what regional health authority do they belong to, what's their age or household structure, do they commute, do they have comorbidities, which we can glean from regional prevalences of comorbidities of interest. What are their behavior probabilities, like what's the probability that they say choose to self-isolate once they become symptomatic, which, there's some period of latency before they become symptomatic. If a household member becomes symptomatic, if they're told to stay home and quarantine by public health during contact tracing, what's the probability that they seek medical care? Again, comorbidity adjusted. We also have out-of-town travelers that come into the province, potentially bringing disease. What does that look like? That was a particular interest to Newfoundland and Labrador. And everybody interacts in their various environments, household, workplaces, schools, etc. We have information about our disease, or at least as best as we can guess it. So early in the pandemic, we were using disease transmission information learned from a previous study in 2012 on pandemic influenza. I figure, well, this is good enough, at least for now. And then trying to, just constantly update the model as more and more information about COVID came into play during the pandemic. So just to give you an idea of the sort of results that we can get. So looking at Newfoundland's travel ban, so you might recall that Newfoundland was somewhat famous for implementing a ban on travelers for the first summer of COVID. They wanted to know, how effective is this policy? Like, should we continue it, because they had actually already just started it when I came on board, and was it likely to have been helpful? So, with our agent-based model, we can, like I said, model all sorts of stuff. Like the columns here are different infection rates of the incoming travelers, and the rows are whether or not contact tracing was implemented or not. So the bottom is contact tracing is on. And of course, they'd be contact tracing. Who wouldn't be? But one of the neat things about agent-based models that you can't do with regular SCIR models is capture these sort of nuanced policies like contact tracing, right? So, if you had contact tracing or didn't in your model, what might that look like, right? How much effort should you be putting into contact tracing? So we can get these nice, pretty curves, talking about, what volume of travelers might have been arriving if there weren't a travel ban, what would their compliance be with the stated quarantine? And we get these, pretty means and 95% confidence intervals of these curves. Anyway, it all looks very nice and easy to digest, but are these figures really interpretable, right? Everybody's showing figures like this for their models for this thing or that thing, whatever they're predicting around pandemics, but are they really showing what's really happening? So I actually dug into this a little bit. So on the left here, we have, mean and 95% confidence interval for just a particular scenario. But in our age-based simulation, we run, 500 or more simulations of every scenario to get a good capture distributionally of what's going on. But if I were to plot just say 50 random samples out of those simulations, we see that they actually look very different from this mean. All right, so this mean here is, it's down here, if you can see my cursor, it's this, slightly higher up dark blue line that ends around 500. We can see that most of these simulations are actually really far below the mean, but there are a couple of these absolutely nuclear scenarios, these great super spreader events, those, butterfly flaps its wings in China and, boom, a whole other country across the world has a pandemic. And those few super spreader events just really drag that average all the way up. So looking at these means is not really telling you anything, right? If I zoom in on these samples, you can see most simulations are nothing like the mean. They're way lower, much more in control, and it's those few super spreader events that drag things up. So looking at this mean and 95% confidence intervals is not interpretable because almost no simulations actually look like average, at least in a very highly granular, highly heterogeneous simulation. So instead of looking at these means and 95% confidence intervals, we instead switch to look at what's the probability of these certain really bad outcomes happening. All right, so instead we switch our graphs to something like this, where the y-axis is the percent probability that we exceed some certain threshold on, for example, the peak number of active cases. So like, let's say here in the middle top, we'd see that we have maybe like an 18% chance of having 600 cases at the worst time in these lower scenarios, like the red and yellow scenarios, which are a high volume, or like regular, rather, I should say, low volume of incoming travelers who are highly compliant with the quarantine, right? So by seeing information like this, it allows policymakers to kind of pick their poison, right? How risky do you want to be with the probability of certain bad things happening versus how much resource and effort and economic hit do you want to take to get those better outcomes, right? So we can see, like, if we were to put contact tracing on, we can see that, like, we never even get to the chance of having 600 people infected, and our probabilities of bad things happening are all much lower, right? But there is still a big difference between low, medium, and high travel volumes, and less difference a little bit about the compliance rates. So that sort of says maybe you don't need to put a ton of effort and manpower into ensuring compliance. If you just put it out there, that should be enough. All right, we can also look at total cases, peak hospitalizations, with the same lens. Although normally I don't present these exact graphs to our public health officials, I more present them in a bar graph format, which is a little bit more easily digestible if you're not used to seeing all of these graphs and curves. Where, for example, for contact tracing, how like what's the daily call load for the contact tracing team? Like how many phone calls are they making a day? We pick out some key numbers like 500, 1,000, 2,000, 5,000. Say under these scenarios, what are the probabilities of each? And then that allows public health agencies to figure out how many people do they want to hire and for how long to do contact tracing in order to be able to make a certain number of calls every day. So the takeaways, right? Once we, look at this in an interpretable lens, we can see the takeaways are very high level because, after all, everything is just only a model of a very uncertain disease where there's no ground truth, because it's not like we can sample every single person in a province and know whether or not they do or don't have COVID on any one day. It's just contact tracing is very effective, but it's not enough to stop exponential spread. The travel volume and infection rate are bigger factors than quarantine compliance, and that the travel ban was likely critically important to mitigating COVID spread early in the pandemic. All right, but we get all of that by looking at the interpretability, by focusing on the interpretability and making sure that we're looking at results that are reflective of the analysis of the actual outcomes of our simulation, and not just what looks pretty and what people expect to see. So Then, in the throes of COVID, we were very frantically always, running the simulation model. And by we, I mean me, staying up until the wee hours of the morning, especially with the time difference with Newfoundland to get stuff done. But once things slowed down a little bit, we could think, what's a better way to go about this, right? The agent-based model is fantastic, and it's, like I said, very granular. We can incorporate all kinds of stuff, but it's not user-friendly, right? It's run on a cluster. You have to launch it by command line. The outcomes are, just a bunch of text files that then you have to read into in MATLAB or Python or whatever and do all of your graphing and, analysis. It's not for the faint of heart. And it really requires a technical expert to run, and it takes time to run, say, 500 simulations of a dozen different scenarios that might be of interest that day. So the question is, can we use machine learning to predict the ABS outcomes, which would be much faster than actually running the simulation, and then create a web tool that would allow policymakers to just test their own policies? Hey, you have an idea about what if you did this policy or that policy? Or what if the newest variant is this thing or that thing, right? It's all just, numbers that you type in. Press go, and you can get a prediction based off of a large data set of possible ABS outcomes that we created. So I had a team of undergraduate students in industrial engineering create this web-based tool and do the machine learning. So they call this tool COPS in their infinite cleverness, COVID-19 Outcome Prediction System. And like I said, it's web-based, so it's really accessible to anyone at any time. We created a data set of ABS outcomes for a broad range of policy scenarios and disease scenarios. And then we clustered these scenarios into good, medium, and bad outcome groups. So if you have an idea about a scenario, hey, what if we had a school closure policy that looked like this or like that? If it comes back and said, no, that's a bad scenario, well, then that's it, right? You stop talking about it, move on to the next idea, right? Even if it comes back medium, if it comes back saying like, hey, this is maybe a good scenario, well, maybe that's the time that we go and run the simulation so we can get very detailed and granular output. And the web interface looks, something like this. So this is the results page, where you can just get some, high level information about whatever data you put in, and some information about these good, bad, and medium clusters, and where does this particular scenario fall in. In the world of vaccine prioritization, we again, we return to our ABS, and we look at all the people in our network, and any contacts that they have with anyone else creates a contact network. Okay, so people are nodes, contact between them are edges. And what we want to do is we want to remove, vaccinate nodes, people, in order to maximally disconnect this network so that if one person gets infected, they don't have the opportunity to spread that disease as far as they could, because most people, their network stops at them in terms of transmissibility. So for example, we look over here in this corner, we can see like if I were to vaccinate this person, it's like I'm removing all of their links because disease can't transmit through them anymore. So you can imagine if we remove enough of these links, all right, COVID might happen or whatever pandemic might happen, but it'll stay locally confined. So we've built lots of very nice mathematical optimization tools to come up with solutions to these problems on very large networks, like a 500,000 node network of Newfoundland or 6 million node network of Greater Toronto Area. But the thing about this network optimization is that it returns a set of nodes, like node 3, nodes 702, etc. That's not actionable, right? Because the age-based simulation is just a statistical representation of the population, not like, the whole big thing. It's not like, Mrs. Smith down the street, and even if it were, that's not really implementable. So then what we do is we use decision trees on the people who were selected to be vaccinated in order to create interpretable and actionable priority groups. So over here on the left, we have our basically decision tree that defines the different priority phases. And we can compare that to the real world phases that were rolled out in Newfoundland. And well, frankly, they're basically the same across the world. So phase 1, frontline and high risk individuals, then basically going down in sort of 10-year age brackets until you get to phase 3. So our decision tree that we came up with is actually quite a bit different, although we did tack on frontline and high-risk individuals at the top. We manually inserted that for phase 1 because that's not represented in network topology, but it is important. And we can see that our priority groups actually focus on large households and the ages of people. So basically people age 18 and under, in other words, in high school, and therefore contacting lots of other kids all the time, every day, should be given priority. Okay? And if we look at what that does with breaking up the network connectivity, we can see here in red and blue are two different algorithms for solving our big network directly. We can see that the raw network solution is very good, right? Even if we're only administering 5,000 vaccines a day, which is about what Newfoundland is doing. I know it seems low, but Newfoundland's a small province, so everything is relative. So our raw network solutions are excellent at disconnecting the network. This black dashed line is actually just random vaccination. In other words, no phases. Everybody just go get vaccinated however you see fit. And you can see that our decision tree approach, both with and without that additional healthcare worker bit put in there, are about the same as randoms. Those are the yellow and purple lines. So that's not super great. But on the other hand, the three-phase realistic ones, so starting with healthcare workers on the vulnerable and then going down in age groups of 10, is actually much worse than random. Oh, isn't that interesting? All right, although of course, real world phases were also thinking about disease severity down the line, whereas we're only thinking about connectivity, although we did put in high risk groups right at the very beginning, but there you have it, sort of interesting. All right, although we can at least see here that we can vaccinate those high risk groups and healthcare workers without any real impact to how much we can mitigate the spread of disease, because ultimately those are not really very big groups compared to the rest of the population. So speaking of severity, another work that we did is trying to predict at the time of PCR testing whether or not somebody was likely to have a severe COVID experience. And I really want to emphasize this is at the time of PCR testing, no doctors, no hospitals, no blood tests, no images. Basically, a person shows up to have the swab up their nose and reports some individual symptoms. What can we do with that information? So at the time that we did this study, Newfoundland had only about 250 COVID cases in grand total. So it's a very small data set. But a lot of medical machine learning is like that. We have really very limited availability. So it's just what the patient says, like their comorbidities, whatever they're complaining about, their symptoms. And again, like I said, we have relatively few patients. Compounding that problem is that there's a severe class imbalance, meaning the vast majority of people who have COVID do not have severe outcome, but we're looking to capture that very small group of people who do, right? So it's a good thing in real life that this class imbalance exists, but it just makes the prediction a little bit harder. Although we were able to get really quite good prediction results. So if you're familiar with AUC of 93, that's basically a balance of true and false positives. We could see like a confusion matrix. We're doing a very good job at correctly predicting the not at risk and at risk individuals. And then on the interpretability front, over here on the right, we use what's called SHAP values. So we can look at all of the features that we had, and a lot of these features we actually manually made and grouped together and whatnot to see what's really important. So like right at the top here, we have the symptoms feature group, which basically says, do you have symptoms at all? That probably means you're more likely to have severe outcome. Respiratory symptoms, definitely going to put you more into that severe category. Age, shortness of breath, fever, etc. Those all put you higher up. But a lot of information people thought was very important, like IHD, COPD, stroke status, etc., ended up actually not really being very important, at least with this particular data set. So again, very specific to this region. So in conclusion, there's lots of opportunities for interpretable AI in the pandemic space. So improved disease prediction, improved policy design, improved medical decisions, advanced warning for resource planning. So if you're operating a bunch of testing clinics and you see like, oh wow, there's a big spike in people who are likely to be severe, that might give you 3, 4, 5 days warning for your hospitals and their emergency departments to allocate the correct amount of resources that they're going to need for a surge. And again, you can put control in policymakers' hands by creating interpretable and easy tools that they can operate themselves. So future work on our end is, just doing things better. Of course, a better prediction of pandemic outcomes, better vaccine prioritization by learning policies directly on the network. We're also working on including equity decisions in making those vaccine priorities, and then building a chat GPT-like interface to interact with these prediction tools in a natural way. All right. And so I'd like to acknowledge our collaborators and our funding sources. That concludes my talk.
Thank you very much, Dr. Dionne. Very interesting work. And I will have any question from the audience first. But yeah, you can.
Yeah, I allowed Kuganya's mic, so you can unmute now.
Able to hear me?
Yep.
Okay. Sorry. Thank you. That was a really great talk. I just had some questions about maybe the disease severity part. You mentioned that it was kind of like a smaller sample size. Like, is there a way that you were able to handle some of the imbalances there, especially because if a lot of patients were ending up hospitalized, like how would you account for those that didn't?
Yep. So we tested a lot of different machine learning approaches. Some of them more explicitly tuned for class imbalance than others, like XGBoost and autoencoders. We found were both really good at capturing these rare outlier events, along with a one class SVM. Although these results are not one class SVM, I think these results here are XGBoost.
Was there any like correlation or collinearity in some of the features that are being represented?
Yeah, so we did actually do a big analysis, just looking to see like combinations of features that people would have, as well as your typical collinearity analysis of features. And we did have some, but some of it is because we artificially put information in there. Like, for example, we have a fever symptoms group, as well as just fever, if you can see here where my cursor is, that are very similar to each other. But fever symptoms include not just fever, but also like feeling like, like you're hot. Do you have the sweats? Do you have the chills? Do you have like the rigors? So all of that, in addition to the raw features, we created just, like that group, which are separate from fever itself, but it has a lot of relation to those other features. But we found that when we created these sort of aggregated groups as well, that we got not only better results, but something that's a little bit more implementable by the public health agencies, because they can easily tell, the nurses who are, doing the swabs, like, hey, if they've got anything related to fever, then, send up a flag here, maybe let them know that they let that patient know that they might want to go seek medical care sooner rather than later, rather than having a bunch of like very specific things like, oh, well, if they're hot or sweaty, then this, or if they're cold and have the chills, then that.
Thank you, Dr. Dionne. We have a couple of questions in the chat. One from Danielle. Is there anything out there on policymaker capabilities, understanding related to modeling or machine learning? Like, is there a general basic knowledge among policymakers that you're aware of?
I will say not that I'm aware of, but definitely it's something that comes up in all of my machine learning research, which is all related to, healthcare and medical decision making, not just for COVID. But there's always, a lot of discussion at the beginning, meeting with our clinical collaborators about what is, and more importantly, what isn't machine learning. What can it tell us? More importantly, how to be suspicious of the findings, how to critically evaluate what you've got. One thing about machine learning, it's funny, like the world of optimization, for a long time I had trouble getting into, healthcare. It's difficult to find collaborators because everybody's like, no, people aren't widgets. You can't just treat them like little parts of a mathematical equation. But that's really what machine learning is. But somehow everybody loves it and thinks that it's magical and it can predict anything. And, you get to a point where lots of doctors and clinicians or their residents have some familiarity with, say, Python. So they just roll up to Python with the big data set, dump everything in, they get some results and they think they've done something fantastic. But then, they want us to come and do something better. We look at what they've done and we're like, well, no, this doesn't make sense. You're trying to predict, say, post-transplant survival, but you included a bunch of post-transplant features in your data set. So like, that's not fair, right? That's not the information you would have at the time of decision making. Like making sure to go back and look at, for example, these like SHAP plots or something else about feature importances to make sure, like, is your model doing something that at least seems reasonable, or is it really like, grabbing onto some piece of information that isn't actually correct? Like what's really going on? And it's constantly, a discussion almost at, every meeting where new results are shared, to go back and say, no, this is not multivariate analysis. No, we're not just going to remove all of these features because you don't think that they're important anymore. Like, there's still value there.
Yeah, thank you. And I think that the keyword that you use is like interpretable machine learning, which I think that is the key added on. There is also a couple of more questions. One related to stats in the spread scenario chart that I think that you showed at the beginning. Why is the 95% confidence very tied to the mean trend line, having all those outliers with, like, I guess?
Yeah. It does seem strange that the 95% confidence interval does look so, nice. But, we're running, say, 500 simulations, and maybe only, 20 will be something really wild. So the confidence interval is still ultimately very tight and very pretty. That's just how it ends up being, just a numbers game.
Okay. And then I think we'll have one question from the audience, Oliver.
Hi, yes, great talk, really, really interesting. I look forward to kind of reading more about it. I just have a question. This might be a little bit minority report, but can you use this model to kind of predict who may be a super spreader, or just when a super spreader event may occur? Thank you.
Yeah, so one thing that we're working on now with our, web tool to predict outcomes is really focusing on, how likely is there to be one, like a super spreader event. So predicting rare events out of simulations. And there's some literature in the area, although what we're finding is that, our model is much larger and messier than most models that have been examined for predicting rare events and simulations. But it is actually an area of research that we're working on now. As far as predicting, who might be a super spreader, we can go back to our contact networks and you basically look at, like, who has lots and lots of connections. That person might be a super spreader, but ultimately, like that contact network, those people, they're just statistical representations of the population, right? Doesn't really correspond to real, Mr. Smith and Mrs. Jones, anything like that. So, being able to understand, like, are there groups of people that seem to, have high contacts? Should we be focusing on them? And that's actually what a lot of our policy decision-making decision tree is pulling out. Like large households, you have a lot of contact with the people in your house, right? It's inevitable no matter what you do, no matter how you might try to quarantine. And if you're going to school, particularly in, high school, there's a lot of contacts, in the classroom, in the hallways, in the communal lunchrooms. So, those people are really being emphasized when we try to, sort of back out some actual group-based rules of who is selected for vaccination.
Okay, thank you. That was a great answer. Thank you.
Okay, so we are at time, so I want to respect everyone's time and get you going. I just want to thank Renzo, Dionne, and Andras for attending today and giving some information. So for me, it's really interesting to see the varied research we have in the Institute for pandemic-related research. So thank you for sharing that today. For the graduate students, our next workshop is going to be December 1st. It's our first soft skills workshop on communicating via writing. So information will be shared about that shortly, so you can register. Other than that, I hope you all have a great weekend. Thanks for attending.
Thank you.
You all. Okay, bye.
Thank you. Bye.